Hi, I'm Rachel Weiss from Menopause Cafe charity, which I started back in 2017 because I knew nothing about menopause and I knew it was going to happen soon, and I wanted to have a chance to talk to other people and find out more about it. And I'm really happy to be talking to Laura today, who knows everything about the menopause.
Thanks, Rachel. Hello, I'm Laura Jarvis, and I'm an NHS menopause specialist, and I'm also a trustee of Menopause Cafe charity.
Great, and thanks for joining us, because I'm quite excited. It's our first video podcast, so we'll see how we get on. But we're aiming to cover kind of general knowledge, what everyone needs to know about menopause, whatever your age, whatever your gender, how it might affect people's lives, your own life, or people you live with or love, and what we can do to make it a bit easier to get through for those who are suffering. How does that sound to you, Laura?
Sounds good.
I think we should kick off by defining our terms. What is menopause?
So menopause is essentially when the ovaries stop producing estrogen and our periods therefore stop. So the official definition is that you have to have had no periods for a year. But often it's a bit more complex than that to make that diagnosis, because people might be using hormonal contraception
And not having periods, yeah.
Exactly, yeah. So for example, maybe having a marina, and which is
Coil,
stop the
yeah.
periods. So in that case, we would have to very much go with how people are describing their symptoms, so how they're feeling.
Which is why we'll list lots of symptoms in a moment. I was just thinking, I know for me, one of my perimenopause symptoms leading up to menopause was my periods became much more irregular. So I get the point about it having to be 12 months without, not just I haven't had a period for 3 months.
Yeah,
That's
exactly.
them done.
Yeah, because your ovaries will almost getting a bit tired, and some months they'll have a bit of a break and they won't release an egg, the hormone levels have dropped, but then the next month they might wait. But sometimes you might go like 9 months without a period and then have a period. So you would still classify that as perimenopausal.
Because they haven't stopped for a year yet.
That's
It
right.
reminds me a bit of starting periods when they were quite irregular at the beginning as the hormones were kicking in.
It's exactly the same. Yeah.
Thank you. Now, I know the average age in the UK for most ethnic groups, I can't just be for white people, I don't know, it's 51, and I know it's lower for people like me who are of South Asian descent. But I believe there's quite widespread. Is that right? Can you say a bit more about the different ages people might experience menopause?
We would certainly consider 45 to 55 as being the kind of the average. However, people having a menopause before the age of 40 would be considered an early menopause, and then obviously a premature menopause would be much younger than that, sort of age 35 and below. Yes, that's a smaller number of people would be experiencing that, but nevertheless that's got huge significant effects for somebody, quite catastrophic in some cases.
I can imagine if they were hoping to have children or all sorts, and if their period stopped before they're 35 and they're getting the perimenopause symptoms, then they could be having the symptoms in their 20s.
Yes.
And think I'm too early for menopause. It can't be this. Yeah. And sadly, I know a few people can have menopause in their teens, late teens and early 20s as well.
Yeah.
So it sounds really important that we know what the symptoms are and can have some idea what's happening.
Absolutely. Yeah.
Just before we get on to the symptoms, Laura, that's what we might call natural menopause, and it just stops. But I know some people will get catapulted into menopause with a surgical or a medical menopause.
Yeah.
Can you tell us a bit about those two?
Yes, of course. Essentially, any reason why you might have to have your ovaries removed. So if you've got very bad endometriosis, for example, or you've got cancer diagnosis, or some kind of ovarian cyst, you might have to have your ovaries removed. And that would basically induce a very sudden and quite an extreme menopause, whereby the estrogen levels literally plummet overnight. The other category, as you described, is where we actually induce what's described as a menopause, a medical menopause, whereby we give hormones to completely block the ovaries from producing hormones. And that might be a treatment, for example, for endometriosis, where we bring on a menopause.
Medically induced one.
That's right.
And that always sounds really tough to me if someone's facing cancer or endometriosis or some other health condition.
Yeah.
And they're all concerned about that, and then suddenly they've got menopause as well, and rather suddenly and brutally. Most of us, the menopause happens gradually over the perimenopause period.
Absolutely.
Rather than suddenly stopping.
I think it's it's like the sting in the tail, really, isn't it? Because you're already dealing with the implications of the condition that you have, and then it's like a double whammy to have this on top. That can be often I've heard people say things like, for example, getting through the cancer treatment, and the radiotherapy, chemotherapy was okay. But actually when the menopause hit me, after all of that, was
It's sometimes the last straw, isn't it?
Yeah.
Yeah, we get people who come to the menopause cafes talking about their surgical menopause, and they say the other hard thing is, say they're in their 30s or 20s, none of their friends are going through it at the same time. So they can feel really alone.
Yes.
And sometimes they feel they should be grateful because the surgery saved them from cancer, but actually they're gutted.
Absolutely.
Yeah.
Yeah, there is. It's just made me think about, it's a really good resource actually people can turn to, the Daisy Network, which supports younger women. Yeah, because you're absolutely right. They can feel very isolated, very alone, and none of their peers are experiencing that.
Yeah, so Daisy Network.
Yeah, Daisy Network's very...
Google that, folks, for anyone who's having an early or premature
that's right.
menopause. Okay, why don't we talk through some of the more common impacts? I always hesitate to say symptoms because it makes it sound like it's a disease, whereas actually we don't talk about the symptoms of puberty. We just say when you go through puberty, you might get spots and have mood swings and have irregular. I sometimes wonder what would it be like if we talked about menopause just as a transition.
Yes, I think you're right.
Different
you have to
effects.
be careful not to over medicalize what is essentially a natural transition in our bodies. But so yes, let's try not to use the word symptoms if I can.
We'll see, don't worry. But I think I just want to point out to people listening, first of all, that my understanding from the British Menopause Society survey, I think it was 2016, is about 20 of us will sail through our menopause relatively lightly. We'll only get the 3 major long-term symptoms that everyone gets. And another 20% will be really debilitated. They could feel suicidal. They could find it hard to continue their jobs. They have a horrible time. But that still leaves 60% of us in the middle who may be muddled through with a bit of help.
Absolutely.
Lifestyle and medication. So when we're going through these symptoms, listeners and viewers, do remember you might not get all of, some people will get all of them. You might just get through with the 3 long-term ones or get a few of the ones in the middle. It's a bit like pregnancy again.
Absolutely. I was just thinking that's a really good analogy, because everybody's got a different, every individual you speak to will have a different story, won't they, about their
And some of them will be horror stories and they're all terrified, and others will just, is it bloom or glow, whatever we're meant to do. All people, and then most of us are somewhere in the middle.
That's right.
Okay, so tell me some of the more common impacts that...
So in the ones that we classically hear about are things, aren't they, like hot flushes, night sweats, difficulty sleeping, anxiety, mood swings, achy joints, dry skin, the list goes on.
Itchy skin.
Itchy skin, yes. I almost hear of a new menopause symptom every week, really, because estrogen is in our whole body, so every system. And then also we mustn't forget about the genital symptoms as well, vaginal dryness, bladder symptoms. They're often a bit neglected. So yes, and dry eyes.
Electric shock sometimes.
Yes.
Skin. There are about 34 symptoms. We might include a link to it.
I know. So they are. There's numerous. Yeah.
And thank you for explaining and reminding me it's because estrogen is in every part of our body. It's not just our ovaries. There's a great booklet, Understanding Menopause, produced by Menopause Support, which gives a checklist. There are lots of checklists of symptoms, and that can be quite a good one to go through and people to tick which symptoms they've got. And that's, as you said earlier, one of the best ways of diagnosing it. Is that right? If you've got a cluster of symptoms. I know some people ask for a blood test. Do you want to say a bit about when that's appropriate and when it's useful and when it's not?
Yeah, certainly, yes. There's a hormone called follicle stimulating hormone. We call it FSH short, I
always forget what it stands for. So just say it again. Follicle.
It's basically the hormone that comes from the brain, and it's telling your follicles and your ovaries to
produce,
get going, stimulate them to produce an egg. So as the ovaries start to get a bit tired, the follicle stimulating hormone the levels go up, and it's putting pressure on the ovaries, if you like, to produce some eggs. So if you find that the levels of the FSH go high, now that's very useful if somebody's under the age of 45 and you're actually not sure. They're coming to you with a list of symptoms, and for example, they might have a marina in place, so they're not having any periods. So that would be very useful just to because it could be any other reasons that you might be getting insomnia, headaches, you might be feeling anxious for any number of reasons. So it can be useful in those situations to do a FSH. But to be honest, any person over the age of 45, if they're coming with those symptoms, you don't need the blood test really, because the obvious thing is it's likely to be
Menopause.
perimenopause or menopause. Yeah.
And I believe the FSH levels vary. So even if you did do a blood test on one particular day, it might be a day when it's low. So it can't tell you for sure. You'd need to repeat it.
You do need to repeat it 4 to 6 weeks. Not 46, but 4 to 6 weeks.
Yeah. So most of us, if we're over 45, the blood test isn't useful.
Not helpful. Yeah.
We can diagnose menopause, all the symptoms.
That's right. Yeah.
And how it's affected. And I'll just say a bit about how it can affect us at work. Like I started forgetting things. So that affected me at work as well as at home. And I had to start writing things down. Asking people to email me rather than tell me things. And if people aren't sleeping well, which is one of the symptoms people talk about a lot at the cafes, then that has a knock-on effect at work, a bit like if you're sleep deprived with a puppy or a baby, but it goes on and on. And if they're embarrassed to tell their boss or to ask for flexible hours, it's inconvenient to say the least. And I know people consider leaving their jobs or not going for promotion. And vaginal dryness, which you mentioned, can make penetrative sex uncomfortable or painful, and then that can have an impact on relationships.
Absolutely. And that's often something that people understandably maybe feel a bit embarrassed to go and see their doctor about. So that's why we really want that to be included in as many information and consultations as possible, with the clinician inquiring about that. Because
even if the patient doesn't mention it, to ask,
because it's something
about vaginal dryness.
A lot of women now are much more comfortable, but some women, depending on their culture, and maybe just feel uncomfortable talking about sex, such things.
And I think that's why we started the charity, is to help people who come to the cafe be comfortable saying the word vagina, saying the word menopause, because often they don't feel able to tell their sexual partners why they don't want sex anymore. And it's because it's painful. And then he or she will think, oh, it's because of me, and relationships can break up. So the more comfortable we can get talking about our bodies, really.
Absolutely.
And there is help available for vaginal dryness.
Absolutely.
Shall we maybe move on to things we can do there?
Yes, exactly. We can use some little bit of estrogen that we put straight into the vagina, and that can come in different products. And the great thing about that is even women who maybe don't want to use hormone replacement therapy or can't use hormone replacement therapy for some reason, most people can use vaginal estrogen.
The estrogen and the pessaries. I think that's so important for us to know, that even if we can't take systemic HRT on our whole body. And am I right, at least in the UK, we can go to a pharmacy and buy that over the counter, the vaginal estrogen?
That's a relatively new thing, actually, whereby you can get the little pessaries, over the counter. Obviously, you need to pay for those. They would be available on prescription from your GP. If you just want to go in and buy them,
you can, or you can ask for it on prescription. And that reminds me to come back to what the 3 long-term symptoms, because a lot of the ones we talked about, like hot flushes and itchy skin, are what you might call medium term. Is that right? They might last for 7 to 10 years, although for some people it goes on longer. But I believe that all of us, even people like me who've sailed through, I will still have a drier vagina, even if I can't feel it, and that could lead to bladder infections and UTIs, and reduced bone health and reduced heart health.
That's right. Estrogen is responsible for protecting the bones against osteoporosis or osteopenia, thinning of the bones. So it explains why women have a higher incidence of osteoporosis, which leads to things like fractured hips as we get older.
Falls.
And then obviously cardiovascular disease. So it's interesting, estrogen protects cardiovascular system, but after the menopause, then our rates of cardiovascular disease increase, unfortunately. Obviously that's multifactorial, and also in lifestyle factors are extremely important as well. But estrogen is one part of that really as well.
So while we're fertile, estrogen protects us.
Yes, it does.
And we have a lower rate of heart attack and heart diseases than men do. But once the estrogen protection goes, our risk increases, but just increases to roughly the same as the men. Is that right? Rather than, I know sometimes people worry that it increases through the roof.
It just catches up almost with men. Thank you. Important.
Lifestyle changes and medication. Those are the 2 main things we could call them 4 if we spell them into healthy eating, exercising or being more active, and sleep and relaxation, and then medication, which could be HRT or pessaries.
That's right. Okay. Yeah.
Where should we start with the lifestyle and the
Lifestyle.
medication? Yeah.
Yes, I think when I see a patient who comes in to talk about menopause, we really try and do a very holistic look at that person and a very individualized approach, looking at everything from her past medical history, existing heart disease, for example, or things that increase her risk of osteoporosis already that she may have. And then we would go into any medication that they may be taking, which, could impact, for example, long-term steroid use would impact on osteoporosis use, for example. And then family history is very important. So if you have a family history of early menopause, say, or family history of breast cancer, very young, all of these things are important. And then social history. So thinking about what kind of a lifestyle the person has. Are they active, taking weight-bearing exercise?
Yeah.
Do they smoke? That's important to advise about that. Alcohol, of course. We're not saying don't drink alcohol, but just try and drink within recommended government amounts. And like you said about, so I think stress is really important in the menopause. So if you have what you're doing for a living, if your job's very stressful, how that might impact on your whole
your whole
well-being
system.
Yeah, absolutely. So we look at all of that really and advise on depending on the areas, more exercise, and also diet, of course, is very important. And I think we feel like we're learning more and more about how important diet can be as well, and the general well-being. So really try and look at all of that before we then talk about hormone replacement therapy. So
we'll just think through the lifestyle stuff first and then move on to that. Because I know some of my friends have been advised that they need to lose weight before they can take HRT. I'm not quite sure if that's true, but yes, I think we all just want a silver bullet. Give me a pill to swallow that will cure my menopause. And it's quite hard to accept that actually I need to take some responsibility for what I'm eating and how active I am, and learning relaxation and de-stressing and maybe saying no to people. And that's all hard work when you're already generally often squeezed between kids, aging parents, the peak of our career, and feeling crap the whole time anyway. So I just want to say to people listening and watching, it's like the news we don't want to hear, that we need to look after our bodies. But for me, it was a bit like Mother Nature's kick up the backside, going, Rachel, you've got to start looking after yourself. I'd never exercised before, and I can't say I enjoy it. I keep waiting for those endorphins to kick in. But I think of it like brushing my teeth. This is something I need to do, this eating healthily stuff and this exercising, if I want to live longer and healthier. And also trying to relax and de-stress, which again sounds impossible. But now, I like to think if we learn all these things now, it will actually help for the decades ahead.
Yeah, definitely. I think it is a good time to stop and take stock of your life and say, we're living a lot of our lives now in the postmenopausal years, aren't we? And we really want to be living, not just living a long life, but also living a healthy life.
A happy and a good life.
Good life, yeah.
So it is a pause. Maybe that's why it's menopause, to just stop and think.
Right, and it can be really helpful just to look at maybe some bad habits you've crept into over the years because you've been so busy raising a family, busy with jobs. Now's the time to really invest in yourself. Yeah.
It is time to put ourselves first. And many women have been socialized in the way that we're brought up, not to put ourselves first. 100%. But we're here to serve, to put our families or our job first.
Yeah.
Or anybody else first, often.
Absolutely. Yeah.
So it can be quite, I know some people find counselling useful, or talking to other people and getting a bit of solidarity from their friends on putting themselves first and saying no to a few of the requests that other people make on us. Let's talk about the ways medication can help. And the first one that's recommended is hormone replacement therapy.
So
or
we'll talk about
MHT.
that. Should we talk about hormone replacement therapy? Firstly, there are other things like complementary therapies that we can talk about as well. So hormone replacement therapy is probably the most effective treatment for menopause symptoms. It's been around since the 1940s, actually, but it's gone through a kind of rocky road, really, hasn't it, over the last 80 years So we are where we are at with it now. We have a much better understanding of hormone replacement therapy, how it can help, and all the pros and cons to it, which we're in a good position, really. Essentially, what hormone replacement therapy is essentially the estrogen hormone, which is what our bodies really want. But for most women who still have their uterus, we have to give some form of progesterone as well. So that can be in the form of a patch or a tablet, or sometimes the Mirena, like we've spoken about before. So it's usually 2 hormones combined, and that would be what we've described as combined HRT, which these two hormones. It's a little simpler if you've had a hysterectomy or if you've got Mirena in, because then we can just use the estrogen-only HRT.
And that's got a lower risk, hasn't it?
Yes,
what
that's
people are
right.
worried about, which is breast cancer. Yeah.
Correct. So we think that estrogen-only HRT may just confer a very small risk of breast cancer, or perhaps none at all, which is wonderful, really, because that's the thing that people worry about with HRT, isn't it? And it can be delivered in different ways. So usually through the skin is our preferred way these days. So in a patch or a gel or a spray. There's also an implant, but that's going a little bit out of fashion now, and we very rarely use that, actually. And there is oral, we do still use oral HRT, but that does carry a slightly higher risk of blood clot. So we certainly would be careful with the people we choose to use that with. Yeah.
And that reminds me, there are small health risks with HRT, whether it's cancer or blood clots. Yeah. And am I right? It's a question of balancing that against the benefits, which are usually huge for people, but that's why it is on an individual basis.
Absolutely. I think that's why it's so important to have a one-to-one chat with a clinician, because everybody's risk is so different. If somebody's sitting there with a mum who had terrible osteoporosis and ended up with fractured hips at age 70, you'd be saying you're swaying it towards HRT. Whereas if somebody's sitting there with a mum who had, or themselves have had breast cancer, then obviously that's quite a big negative contraindication. Yeah. So,
but if someone's suicidal and can't work and has no history of bone problems or cancer, then that's HRT could be a real help.
Absolutely, because in that case, it's usually impacting on that person's ability to live and work. And so don't rule it out. Keep an open mind, is I think what I would say. It's interesting because people become quite fixated, and I'm not taking HRT.
Or everyone should take HRT.
Yeah, well,
black or white. Yeah.
Totally. It's just...
It depends.
Yeah, totally.
I think when we're so confused often and desperate, we just want a simple answer. Is HRT good or bad? But the more people I speak to, it's like, it depends. See somebody who'll listen to all your case history and figure. And then, am I right? You still then have to do a bit of trial and error with the dose and the type.
Absolutely. And this is really, I find this so fascinating. You can give somebody a small 25 microgram patch and they feel great on that. Or somebody else might not even touch them, and they need to be on much, much higher dose, like 100. Right. So it's fascinating.
We absorb them at different rates.
Right. And some people don't absorb well through the skin, it transpires. Yeah, very interesting. It's fascinating, actually. So we have to, one size definitely doesn't fit all. It's a very individual approach.
And I've read that we ought to see our doctor or GP. If we're getting HRT, we should be going back for regular reviews to see how it's...
Yeah, that's right. An annual review is recommended, just to update your history, make sure nothing's changed. Blood pressure and weight's usually a good idea. And just to tweak anything, that needs tweaking. Yeah.
And I know at the moment, some people are very keen to be given testosterone.
Yeah.
Or they want HRT because they think it will prevent dementia. Sorry, that's 2 questions at once. Tell us about testosterone.
Yeah. So testosterone, we have testosterone in our bodies anyway, because people often think of it being like the male hormone that gives you muscles and things. But women, we do have small amounts of testosterone in our bodies. And it's not like at the menopause where it just suddenly drops dramatically. It's more of a gradual decline. But some women, particularly if you've had their ovaries removed, because the ovaries are responsible for producing a little bit of testosterone, the levels will be significantly lower. Some women may benefit, it's particularly beneficial for libido, and that's in fact the only thing that we can use it for with any sort of indication. But other people do report when they try testosterone that it really helps with energy levels and tiredness, but that's very anecdotal. We don't really have...
We haven't got the evidence there. And this is the problem, isn't it? It might be true.
Yes.
It doesn't mean it's not true, but it's been chronically under-researched.
It's absolutely.
As most women's health conditions have been.
Absolutely. We don't have good data, which is why, unfortunately, we don't have a licensed product that we can use for women. We only have the male product,
The testosterone, right?
gel, little sachet. We can pump,
Yeah.
and we use it in a much, much reduced dosage for women, but it's not very accurate.
Because it's been
really-
developed for men and
That's
tested
right,
on them.
Yeah.
So we definitely need research
We
into
do,
testosterone for women and the
yeah.
long-term effects. And
Yeah, I agree. That's a huge, again, a big gap there in the knowledge. Yeah.
thank you. Anything more you want to add on medication or lifestyle?
I was going to
Before we
maybe
move
just
on,
say
yeah.
about alternatives to HRT, of
Yes.
course, because a lot of people, for various reasons, either don't want to use HRT or choose not to or can't. And so really it's worth thinking about other things. For example, some antidepressants can really help with hot flushes and sweats.
Yeah.
And there are some other medication that can help too. It's worth asking your GP. And there are other complementary therapies like homeopathy or reflexology, hypnotherapy.
Yeah.
Really, I'm really open to all of these. I think it would be prudent to mention those alternatives.
And again,
Yeah,
there's not enough evidence yet.
absolutely.
But
Yeah.
anecdotally at cafes, people say acupuncture helps, all sorts.
Yeah.
We're nearly the end, and we haven't said much about our charity yet, have we? Shall we put
Yeah.
something in on that? So we hope that was useful as a sort of introduction to menopause. But what happens at a menopause cafe is people gather of all ages and genders, either online or in person, just to talk about menopause. Like Laura and me talking a bit. We can learn a lot just by talking to other people. What works for one person might not work for another,
Yeah,
as you have said.
absolutely.
But if we can hear lots of stories about how other people have coped, and we really do believe everyone needs to know about menopause.
Yes.
Maybe you're a male boss in your 30s, and if you've got a team of women in their 50s, and of course it happens to trans men and intersex people and non-binary. If you'd like to attend a Menopause Cafe, have a look at our website, which is www.menopausecafe.net. Some are online and they're worldwide. I'm quite pleased, Laura. We started it in Perth in Scotland, didn't we?
Yeah. You did.
Now it's everywhere.
Yeah.
And now they're in Australia, America, Kenya, wherever. And the other thing you can do if you want to show your solidarity for people going through menopause is to wear a menopause awareness ribbon. They're pink and purple. I think they're quite pretty. Forgot to bring mine today. Menopausal brain fog. That's right. That's one of the symptoms. But if you wear a menopause awareness ribbon, which you can get on our website, menopausecafe.net, that shows the world that you are in solidarity and support with everyone who's going through their menopause and that you're open to conversations about it. So get in the workplace, I think it can be quite powerful, or down the pub or on the bus. I've had people stop and start talking to me. So attending a cafe, wearing a ribbon, donate to our charity. Is there anything else that we want to ask people to do?
No, I think you've covered the main things. Yeah, and I just want to say big thank you to you, because you really have started this huge conversation, and it was really needed to be done by some.
Yes, I think the more we talk about menopause, so even if after listening to this podcast or watching it, if someone says, "What have you done today?" or if you can say, "I listened to a podcast about menopause," you're saying the word, and that will show that it's okay and help make this easier, because people feel ashamed. And last sentence, menopause isn't all bad. There's no contraception. I don't have to carry period products around anymore. I don't care so much what other people think about me. I can say what I think. So it's not all bad, but getting there can be tricky.
I agree. I think I think that's really important to put a positive spin on the second half of our lives. It's a new chapter.
It is.
And it's got lots of really good things in it.
Yeah. Thanks very much, Laura. That was nice talking with you.